Hey guys, this is Caesar with Nursing School Made Easy, and today's lecture is going to be focusing on GERD, or gastroesophageal reflux disease, otherwise known as heartburn, indigestion. So let's get right into the lecture. Again, these are all geared towards preparing you for the NCLEX exam. So let's get started. Now, let's first look at a little bit of anatomy so that you can understand this a little bit better if you don't already. So this is going to be my mouth here. Sorry for my drawing. And it's going to be the esophagus, okay? So here we have the esophagus, and then we have your stomach. Now here we have something called the lower esophageal sphincter. Now this sphincter here is supposed to tighten up, okay? It's supposed to get tight every time you swallow. Food's going to come from your mouth. It's going to go into your esophagus. It's going to come into your stomach. It's going to get digested. Now remember that your stomach does produce a lot of acid. Now that acid, it's supposed to digest the food that goes in there, so when it goes into your small bowel, hopefully you begin to absorb some of those nutrients. But remember that acid's going to be pumped in here. So now, if you either have increased abdominal pressure or a weakening of this lower esophageal sphincter, what's going to happen is these stomach contents along with the acid is going to come back into your esophagus, and it's going to make its way up. Now that acid is going to cause irritation, okay, to the esophageal lining, to that tissue. So essentially that is what GERD is, or reflux disease. That's what it is essentially, this acid backing back up into the esophagus. Now again, that's not supposed to happen. Food is only supposed to go one way. Okay? So just keep that in mind, and now let's get into GERD. Now, again, gastroesophageal reflux disease. It's also known as heartburn, indigestion. Again, this is a reflux of gastric contents into the lower esophagus. Just our picture here again, into the lower esophagus. Here's a sphincter, and the acid is going to come back into this area here, causing damage to that area. Again, the lower esophagus. Yes, it can come back up. So the main area of focus is the lower portion of the esophagus. Now, what are some causes of GERD? I think I'm moving my camera there. Causes of GERD. Number one, hiatal hernia, and we're going to do a different lecture, and we're going to talk about hiatal hernia. See if I can adjust this just a little bit. Number two, an incompetent or weak lower esophageal sphincter, and we just talked about if there's any problems with that esophageal sphincter, if it's letting food back into the esophagus, that is going to be a problem, because the food should not come back up. If it comes back up, it's going to come back up with those gastric contents, and part of those gastric contents are going to include acid. So again, a weak or incompetent lower esophageal sphincter is going to cause that. So incompetent, and I don't know why we're shaking here. Again, LES, lower esophageal sphincter, incompetent or weak. Okay. 3, decreased gastric emptying. Now, if you have decreased gastric emptying, it's just going to allow for food to sit in here for a greater period of time. You go to a supine position, you increase your abdominal pressure by doing a lot of crunches. You ate, and now you all of a sudden want to do some exercising. Well, what's going to happen is your abdominal pressure is going to increase, and this is going to push again up into that esophagus, and these contents are going to come back into your esophagus. Okay, so again, decreased gastric emptying That is part of the cause. Now, a big point to remember, and this is for your NCLEX, remember that this problem will increase again in the supine position. And especially, for example, if you just ate a large meal, and especially if you ate a large fatty meal, and then you go down and sleep, lay down. Again, that abdominal pressure is going to increase and going to make it more likely for you to suffer from reflux disease. So people that are at greater risk for this is, number one, obese patients, again just due to that large amount of pressure in the abdomen, and two, pregnant women, again, increased abdominal pressure. Now, what are some clinical manifestations? Again, this is what you want to focus on for your NCLEX. Number one, heartburn. Number two, something called dyspepsia. And all that is indigestion or upper abdomen pain. That's all dyspepsia is. Three, hypersalivation. Now, you're having reflux, you're having a lot of food contents coming back up. Your natural inclination or your natural tendency will be to try and swallow those contents. So that could be a reason for the hypersalivation. You're constantly trying to swallow those gastric contents. So again, make sure you're watching out, paying attention to that patient. Is that patient constantly trying to swallow? Well, again, that might be why. This is a biggie here, non-cardiac chest pain. Again, this is non-cardiac, okay? Just think about where this is occurring. Let me bring my awesome drawing back here. So remember, this is going to be in the middle of the chest. So here we have an arm. Same thing on this side. Arm there, but this is all chest. Okay, so it's happening right in the center of your chest. So you're going to be having chest pain, and it's right in the middle where your heart also lies. So make sure that you assess that patient. If they're having chest pain, you need to find out right away, is it possibly a heart problem, or is it something less serious like heartburn? Okay, again, this is non-cardiac chest pain, and this chest pain will most likely be relieved by something like an antacid or milk. 5, regurgitation. Now, we just talked about, again, the heartburn. This is caused by all those gastric contents coming back into the esophagus. That would be regurgitation. Now, complications. 1, esophagitis. And all this is just inflammation or irritation of the esophagus. Now, this is going to be caused by that, by those acid contents. Because again, you have all that acid accumulating in your esophagus, and that will irritate your esophagus. Now, if this problem is not taken care of, or if this occurs for a prolonged period of time, then you can end up with something called Barrett's esophagus. So make sure you know this for the NCLEX. Again, Barrett's esophagus is just, long story short, a change in the esophageal lining, because that acid is going to be repetitively affecting the esophagus, and over time the lining will change. Now, if that occurs, again, you have Barrett's esophagus, and that is a precancerous state. So these patients will most likely undergo something called an endoscopy and also a biopsy. Okay, so this is important because, again, if this goes on for a prolonged period of time, that constant acid irritation may cause the patient to have cancer. Okay. Now with these patients, the ones that have had the GERD for a prolonged period of time, you always want to be careful and make sure that they are having something like a bleed occurring. Okay. So again, ask that patient, have you ever coughed up any blood? What color is the blood? Is it bright red, or is it a darker color? Because that will determine whether it has gone through the stomach or not. Okay. 3. Another complication is aspiration. Now we just talked about how one of the clinical manifestations will be regurgitation. Well, that regurgitation may lead to aspiration of the gastric contents into the lungs. This will result in something like bronchitis, pneumonia, or asthma. Now, what are some diagnostic studies? Number 1, endoscopy. You're going to want to check the lining of the esophagus, make sure there's no ulceration, make sure there's no active bleeding. If there are some changes to that esophagus, you might want to do, or the physician might opt to do something like a biopsy. Other things that may be done prior to the endoscopy, prior to the biopsy, to see if there is any reflux occurring, would be something like an upper GI. Oops, number 4, or a barium swallow. Now, if you want to know the specifics about them, we can do another lecture, so let me know, but just make sure that you know the upper GI and barium swallow. These are studies to diagnose and see if there is any type of reflux disease. Now, these will be done in the radiology department, okay? And they will be given something like barium sulfate to drink. So patients that do take this barium sulfate, you have to remind them that day after, their stools will be white. Okay, white stools, and most likely, if they are undergoing this procedure, upper GI or barium swallow, they will be MPO after midnight. Interventions. If they smoke, you want to tell them to stop smoking. You want to tell them, if they're obese, you want to tell them to lose some weight. Once you get on the field, you will realize that you're working long shifts. You might not always get a lunch, and when you get home, you might want to snack, and right after you snack, you might want to go to bed. If that's the case, you're eating late and then going right to bed. So for those patients that do eat and then go right away to bed, they're increasing their chances of getting acid reflux disease or GERD. Well, you want to tell them to stop eating before going to bed, and if they do eat, you want to tell them to at least wait 2 to 3 hours before lying down in a supine position. Okay? So if they eat, you want to tell them to at least stay greater than 30 degrees. Again, you want to tell them to avoid a supine position after eating. 4, you want to tell them to avoid fatty foods, fatty, greasy foods. Remember that fatty foods are going to decrease gastric emptying. So again, avoid fatty foods. You also want to tell them to avoid caffeine, tea, soft drinks, chocolate, peppermint, tomatoes. I mean, make sure you know these for the NCLEX, okay? These are not all, but make sure you know at least these: chocolate, coffee, tea, soft drinks, peppermint, tomatoes. Why? Because these irritate the esophagus. I'm not going to write all those, so just rewind and replay. Number 6, eat small, frequent meals. Now let's talk about some medications. Now, to reduce the acidity or to reduce the amount of acid, you can give something like the proton pump inhibitors, or number 2, the histamine receptor blockers, or the H2 receptor blockers. Okay? So number 1, PPIs or proton pump inhibitors. Now these include, and write these down, Prilosec, Nexium, Protonix. Now also know that prolonged use of the PPIs may increase the likelihood of fractures for these patients, and also that one of the most common side effects of using the PPIs is a headache, so make sure you inform your patient of that. Number 2, the H2 receptor blockers. Now that's just my abbreviation, that's not correct terminology there, but again, the H2 receptor blockers. Things like that include Tagamet, Zantac, and Pepcid. Okay, so again, Tagamet, Zantac, and Pepcid. Now again, both of these are going to decrease acid secretions. You can also give something like sucralfate. Now, one of the problems with sucralfate is that it causes constipation. So again, make sure you inform your patient of that. You can also give something else like Reglan. Now that is a cholinergic drug. Now if you're going to give them Reglan, you also have to inform them that Reglan can cause restlessness, insomnia, and anxiety. Another medication that you can give is something like an antacid. Okay, now depending on which antacid you give, the antacid may contain aluminum products. If that's the case, you want to tell them that that aluminum can cause constipation. Some antacids contain magnesium. If they take magnesium, you want to inform them that the magnesium will cause diarrhea. So let me just add magnesium on there. Now, there are surgeries that can be done, and I will speak more about surgical care on another lecture that focuses on more abdominal surgeries, but the 2 types of surgeries that can be done are 1, Lapnesin, and 2, Toupet fundoplication. Fundoplication.